Hey, welcome to another episode of the Go To Physio Podcast. We are at episode 65 or season 4, episode 15. And today's episode is all about improving your therapist's initial assessment rebook rate. So we've spoke a lot over the last few episodes about the Go To Clinic Head Physio dashboard, the Go To Clinic Physio clinical standard metrics, the 6 stages of the patient journey. And we're going to dive in today now, and we're going to focus more on one of these metrics. And in the previous episodes, we spoke a lot about these metrics being the outputs. These are the lagging indicators of something that's already happened, or said another way, of something that didn't happen in the actual session. So with the IA Rebook Rate, why do we want to get interested in that? Well, as we saw in How to Double Your Profits Without Needing New Patients episode a few weeks back, the Clinic A, Clinic B, one clinic has an IA rebook rate of 70%, one clinic has an IA rebook rate of 90%. That means essentially that for 100 patients, Clinic A with a 70% rebook rate has 70 patients continuing out of the 100. They've lost 30 patients per 100 new patients, whereas Clinic B, out of the 100 new patients, they've got 90 patients continuing, which means they've only lost 10 patients. So Clinic A has to find 20 more new patients every single month just to keep pace with Clinic B. So you can see improving your initial assessment rate from 70 to 90 makes a big difference. And our 3 key levers, it's one of the 3 big power levers we can pull of improving your IA book rate, improving your visit average from 3 to 6, improving your drop-off percentage. Gives you essentially a 2.3x growth. So that's why this is important financially, but most importantly of all, it's part of the customer journey, and patients come into us looking for help, and we want to make sure that this metric is hitting standards so that these patients actually go on to actually achieve and receive the help that they wanted. Because call me skeptical, but I'm very skeptical that it's very, very difficult to get long-lasting results that stand the test of time and stand the test of life in one session. My ego told me I could do it when I started on private practice. I quickly learned that we can change pain, and change of pain is very easy, but to actually get the pain to stay away in the real world where there's physical and emotional stressors, that takes a little bit of time. And that's why we want to get that IA rebook rate up as high as possible. So this episode is all about looking at the key actions and inputs that need to happen in order to get this output, which is the IA rebook percentage, up to 90%. Now, there's going to be a bit of crossover with your packages with this. So a lot of what we're going to talk about here will improve your package of care conversion as well. But I'm actually going to create a separate episode for your packages, because there's a couple of nuances that we want to discuss in terms of business systems as well in that episode that I want to keep out of the IA rebook percentage. So the key thing that I will say, first of all, is out of the IA rebook percentage and the bought plan or the package percentage, is the IA rebook percentage is king, okay? And I'll always say to my own clinicians that the package percentage of hitting 50% conversion of that, so if you offer packages of care in your business, that 50% of your patients opt to actually buy into it. I like that as a metric, but the most important metric is that the IA rebook, because again, even if they don't buy into a package, once our PVA is good and our drop-off percentages are good, it doesn't matter about the package as such. It's just nice because it gets all the money out of the way, and it means the business is going to be a lot more efficient as well in terms of what we're spending our time and energy resources on, especially our admin team. Okay, so the IA rebook percentage out of these 2 is absolutely king. Okay, now when we look at our Go To Clinic Head Physio dashboard, we've now focused on our IA rebook rate. We want that to be 90%. We now use our Go To Clinic patient journey framework, and we know that there's 6 stages to getting consistent reviews and referrals. So what out of these 6 stages, or which of the 6 stages are important to improve our IA rebook percentage? That becomes the next question. Well, if we recall from previous episodes, stage 1 that we have to get our patient to pass through, and have undeniable proof that they have passed through stage 1, is we need our patient to buy into our treatment plan. Okay, because if the patient doesn't buy into the treatment plan, it's going to be very hard to get the patient to actually rebook again and turn up, okay? And again, I think that's the clarifying point here as well, is we want our patients to actually rebook and turn up, okay? Again, you could have a 90% IA rebook rate, but then half of those patients don't turn up, okay? So again, you can use that over 2 weeks if you wanted to actually track that to see did they actually turn up again, and can very often tell a different story. So we'll go into that in a little bit more detail of what needs to happen to buy into the treatment plan. We also need the patient to feel the difference in the first session. So again, if they buy into the treatment plan, but they're not really feeling progress, then the self-doubt starts to kick in again. They start to question themselves. They start to question, is this worth my time and money and effort? And do I actually trust you as a therapist to deliver results? So feeling the difference in the first session is overcome a lot of those objections. And then the third stage of the go-to clinic patient journey, which is that the patient actually attends the second session. So there's some key actions in stage 3 also in order to drive that metric of the IA rebook rate. So if we want to improve our initial assessment rebook rate, you can see 50% of the stages of the patient journey are in this metric. Okay, and this is why this metric is the platform then to improving everything else, giving you the time to hit your other milestones within the first 3 sessions, which is stage 4. Your patient progresses even when the pain eases, is stage 5. And then they're exposed to worst case scenarios and they've achieved their definition of success, and they're moving with thoughtless, fearless movement, which is stage 6. So to get our patient to buy into the treatment plan, to feel a difference in the first session, and to actually rebook and attend, the question becomes now, what are the key inputs that need to happen in order to do that? And I always like to look at this as 2 components, okay? And we obviously need to look at the big objections of what's going to stop the patient buying into the treatment plan. So your 4 big objections are essentially time, money, trust in you as a therapist, and self-trust in themselves, okay? And that's going to have a big impact. Self-trust is actually a much bigger objection than people realize, especially patients that have been around the houses that actually trust themselves to do this. So where the self-trust objection comes in is when we design a treatment plan, the treatment plan needs to feel easy, okay? And how we do that is we chunk the treatment plan down into bite-sized steps. Okay, so that's going to be something that's going to be important, that we're looking for our therapist's ability to do that. But before we do that, I want to go back to the very start. And in order to get someone to buy into a treatment plan, that alludes that actually there's some selling to be done. And there's that word selling that us as clinicians tend to hate. Okay, so in order to buy into the treatment plan, we have to sell the treatment plan. Okay. Now, I want you to think of your selling definition in a slightly different way that's actually going to help your subjective assessment. So when we talk about selling, what I want you to really redefine this and rethink about this is, all we're doing when we sell is we're getting someone to essentially buy in to a better vision or version of themselves. Okay? And that's really important. Is in order to sell, we must have someone to be able to imagine a better future, okay? And how does that relate to the subjective assessment? Well, that changes everything that we do in the subjective assessment, because now we're going to have to look at the subjective assessment as simply, and again, I want to put the caveat, or the obvious thing here is, we obviously still need to do all of the basics in the subjective assessment, rule out red flags if there's anything sinister going on. If you think there's pathology present, we still need to ask those questions. I want to get that out of the way, because you'll always have some Tom, Dick or Harry that'll keyboard warrior will come at you. So unfortunately in this day and age you have to say that. But when we look at that with our subjective assessment, what our subjective assessment really is it's an ability to extract from the patient what is their definition of success, how do they see and define their better life, because everyone wants to, everything that we do essentially, it's to improve our life, okay, in some way or form, okay, whether that's you're helping someone else so that you can feel good, to feel better than you currently feel, okay, so whatever it is, we need to understand what it is that our patient defines a better life look like. So that's the definition of success. And then what we need to do is, okay, step one, they can actually see a better future. And again, a lot of persistent pain patients, they're very good at telling you what they don't want to feel, but they're very poor at telling you how they do want to feel. Okay, and this is all part of this getting to buy in. Okay, so step one, I'm really clear on how my patient defines success from this whole experience. Then step two is ultimately getting the patient to see how you can help them get there. That's all the buy-in is. So essentially what your treatment plan is at the top of your treatment plan, and again, if you're watching this on YouTube, whatever, you'll be familiar with our patient storyboards, some of our intellectual property here that we use in the mentorship system. And at the top of that patient storyboard, or our patient V, is the definition of success. This is the ultimate goal that the patient wants to achieve. Okay, and then in between that and where they are now is the other outcomes on the right side of the V. These are the outcomes that your patient has defined as valuable to them. So if we ask high quality questions in the subjective assessment, we can extract those things and then we can map those out. And that's where this becomes important when we talk about the self-trust objection. Because a lot of the times, if you map out a treatment plan for a patient and all you're talking about is exercises, and we're going to do this exercise, we're going to do that exercise, we're going to give you this exercise, what does that feel like? That feels hard, okay? It feels boring. So what happens is the self-trust. Do I trust myself to pay this time and money and effort to get these results? I don't trust myself to stick to this. I'm going to drop off. I can't do this. Okay, so a big objection that you have to come through is self-trust, and that's where actually mapping out the outcomes, making it feel easy and bite-sized chunks for the patient is going to be a big thing getting them to buy into the treatment plan. So if we go back, okay, so the first thing we're going to do is we're going to do this to help you sleep better. Then we're going to get you standing on your leg. Then we're going to give you some simple exercises to do to get you that you can do when you're standing, walking, up and down the stairs, whatever it is. And then we'll ultimately get you back running. Okay, that's a big difference in terms of the outcomes that we've communicated to the patient. Okay, again, they have a lot more belief that they can achieve these things, and these are the things that they've defined. So that is going to be a critical part of getting the patient to buy into the treatment plan. Now, so we've covered there, a lot of this is soft skills. Okay, and it's, again, we coach all this in the initial assessment mastery, follow-up mastery, or subjective assessment in the therapist mentorship is based on this. Okay, so again, it's showing you what questions to use to extract that. So that's the first part that your therapist is going to need to be able to do and improve. The next part that's really important for the patient buy-in is the trust. Okay, is the trust of the therapist themselves. So that bit there, a lot of that in terms of extracting the value from the patient and mapping out the treatment plan, you could actually do all of that even without a good subjective assessment. Okay, you could train a monkey to ask those questions. Okay, well, you probably couldn't because the monkey can't talk. Okay, you could train a parrot. Okay, so we can get the treatment plan out. That's easy. Okay, the bit that we need for the therapist that is often lacking from my experience is their ability to make sense of the symptoms. Okay, so if your therapist isn't confident in explaining the treatment plan, let's not beat around the bush here. A patient can smell bullshit. A patient can smell a therapist who's not confident. So again, if you're not filling me with confidence, why am I going to buy into this? Do I know? So now it's not a self-trust issue. It's not a, do I trust myself to be able to do this? No, it's do I trust you to actually be able to deliver this result for me? Okay, so that's where your therapists need a clinical system that gives them the ability to make sense of the patient's symptoms, identify the gaps of what's not doing its job, and then confidently explain the problem, solution, and plan to the patient. So that's where we use this clinical tool on the left-hand side. So the right-hand side is all the outcomes that they've extracted, and then the left-hand side is the tools that's helping your therapist go from being overwhelmed and having self-doubt to actually into problem-solving mode. So we use this as a clinical reasoning tool and a thinking tool to actually help your therapist think and solve problems. Okay, and that's a big thing that I think is actually missing and overlooked these days, is the actual art of helping your therapist to think, okay, and to clinical reasoning. Because clinical reasoning is such an important tool for us as clinicians, but no one actually trains us or helps us to think. And that's essentially a big part of what we do in the therapist mentorship, is we give therapists a simple system and structure to help them think, connect the dots, and see and find the root cause of the problem, which then gives them the confidence to explain the treatment plan. So you can do all of the stuff I told you at the start, but if your therapist can't make sense of the symptoms, then that's the first problem you have to solve. Because when they're explaining the problem, solution and plan, they're not going to deliver it with confidence. The patient's going to smell bullshit. Okay? So again, I hate to be harsh and excuse my French with that, but it's the truth. Okay? So we need a therapist that has the right private practice skills, that can have a conversation with a patient, extract how they define value, the patient value outcomes. We need them then to be able to conduct an assessment where they can actually make sense of the symptoms and then confidently explain to the patient the problem, solution and plan there. Okay? Now, you might have a therapist that does that, but actually struggles then to communicate the plan. Okay, so that you might have a situation then with a therapist where they can make sense of the symptoms and are very good clinically, but they're very poor at communicating. And a big mistake that I see here being made is that we're trying to drag the patient up to our level with our explanation of the problem, solution and plan. So we, again, in the therapist mentorship, we've got some intellectual property and we've got a process that shows you a tool, frameworks to go through in order to confidently explain the problem, solution and plan to your patient. Okay, we've got a system and a process that we do that. Okay, but most importantly, it comes down to your patient's level. Okay, so instead of trying to drag the patient up, we come down to their level and we do it on their level and we speak their language, which is their patient value outcomes, and we use some very, very simple tools to do that. Okay, so if you have a clinician who understands it, but they just can't communicate it, then you may need to look at that actual way that they're communicating it. And very often then, if we do that, we make sense of the symptoms, we map out the plan that's easy to do, okay, or is perceived as easy to improve the self-trust of the patient, we improve the trust of the therapist, and by having the patient value outcomes there, that's the thing that overcomes the objection of the money and the time, because now we're talking what the patient actually values and they can see the value of spending their time and money actually doing the work to achieve this. So if we can get that right, then we can improve our patient buy-in to the treatment plan. By that point, that's going to do a lot of the heavy lifting for you, okay? And we're going to be well on our way to improving that IA Rebook Rate. Now, there is 2 other stages in this process that we need to consider also, okay? So you might have done a very good job at that point, but then when you go to your treatment part, the patient doesn't feel any progress in the first session, okay? Now, ironically, if you do a really good effective explanation, which is the terminology we use in the mentorship of how to explain the problem, solution plan, how many sessions it's going to take, I always say that's the start of the treatment plan, because there's a lot of reassurance there. As Louis Gifford says, reassurance is a painkiller. Okay, so giving the patient reassurance is the start of the treatment plan, and getting the patient to buy into the treatment plan is the start of that. So they'll, even with that alone, they can feel a difference in the first session. But we may also want to make a difference in range of motion pain in terms of specific to the value outcomes that they've defined. And that's where now the fast start, we call this fast start, okay, in the mentorship. So at this stage, you have to make a fast start. So again, the beauty of this is it's common sense is, look, if you've got knee pain, you do a little bit of hands-on treatment to the vastus lateralis, you get their medial hamstring to do a little bit more, you get their soleus to do a little bit more, you're going to change the patient's pain experience, okay? It's easy to change pain, it's harder to keep that pain away when they go out into the real world, and that's where stage 3 becomes important. But we can use top-down cues with intention of where they're pushing through their foot or hand to change the load that's going through the joint and change pain. Because if we understand that pain is a combination from the peripheral tissues to the spinal cord to the higher centers, there's levers there that we can pull to change the pain. Okay, you just have to understand pain science, anatomy, biomechanics, okay, and you'll change pain very quickly. And that's where in the Go To Clinic Hub, we've got the fast start section for both hands-on treatment and then rehab, which then ties in to stage 3. So we want to do the right hands-on or right rehab to get the difference, or that the patient can feel the difference in the first session. And then to get them to maintain that progress that we've done, that's where stage 3 comes in with the key actions. So I would very much look at stage 3 then as prescribing the right rehab exercises for the patient between session 1 and session 2. Because if we've made progress in session 1, then really what stage 3 is all about is keeping the progress to stage. So how do we do that? We work smarter, not harder. Instead of giving them loads of exercises that we need a load of motivation if they lie on their back and are hard to do, we look at what they need to do throughout the day and we help them be successful. And again, change the low tolerance through the tissues in the activities that they're doing throughout the day. Because the literature and the evidence clearly shows that patients will do the exercises. They might do them the first session of the loyalty to the therapist, but they'll only continue doing exercises that are easy to do throughout the day and that convert the most benefit for them. So to convert the most benefit is the activities that they're doing throughout the day. So I call this a 6 hours versus 6 reps concept in the mentorship. What's your patient doing 6 hours a day? They're the things we need to help them be successful with, rather than giving them 6 reps of something and there's no dynamic correspondence to the patient value outcomes that they've defined for us. Okay, so it's really important that we're prescribing the right exercises to do that. And if you have the head physio dashboard there to understand that there's an IA Rebook problem, we can then use our 6-stage framework here to go, okay, where was the problem? We then use our notes to look at the patient defined value outcomes. So number 1, did the therapist extract the patient value outcomes appropriately? We can look at that, audit that very quickly through our notes. Then we can audit their treatment and how well aligned that is to the patient value outcomes. That's stage 2. And then stage 3, what did they prescribe in the first session for the patient to do between session 1 and session 2? Again, we're looking at how well the patient value outcomes were aligned with the rehab. Okay? Because again, I always give this example because it's easy to understand. We had a situation with a patient. The patient value outcome that we were optimizing for was the patient wanted to sit pain-free for 6 hours a day working. The rehab exercises our therapist prescribed was a mid-foot bridge to get the distal hamstring doing a bit more work, okay, which wasn't wrong, but it wasn't optimized for the outcome that the patient needed to be able to do between session 1 and 2. Okay, so again, we have to think about what are they going to be doing in the week ahead and where are the opportunities to improve their situation, their quality of life, and actually make sure that they feel the difference throughout the week. And again, the beauty of the Go To Clinic Hub now is you look at the protocol for the patient, you look at the skills, the clinical reasoning is all there, the anatomy, the biomechanics, you incorporate that with the pain science. You've got all your hands-on treatment techniques, you've got all your rehab techniques, you've got your fast start techniques. There's no excuse for therapists to be able to do this and pass stage 3, okay? So they're the key actions that I'm looking for in that session. And then, as I said, that gives us then the best chance of progressing your patient. So you can see on the left-hand side, we've got the injury history of the V. On the right-hand side, we want to be seeing, essentially, when we're auditing our therapists, when you look at their notes, how well did they do at extracting how the patient defines value? Okay, or are they just talking on the level of range of motion and pain? How is your patient defining value? Because value, the only thing that matters with value is perceived value of the patient. How does the patient perceive value? Because actual value is only delivered when we deliver how the expectations that they were perceiving. Okay, so again, I've got an example here. If you're watching this on YouTube or if you're not, it's the patient storyboard V again. And it's a patient that on the outcomes on the right hand side, it says wall drills, it says press ups, and it says rebounds, which is one of our internal terminologies for a rehab progression against the wall for an upper limb injury. Okay, so the outcomes that the therapist extracted here is the patient wants to do wall drills, press ups, and rebounds. But looking at that, you have got no idea how that patient lives their life, okay? Because it's not patient-defined value outcomes. With this patient, they want to sleep, they want to get up and down off the chair, walking stairs, and they're a runner. And I can tell that within a second of looking at their patient value outcomes. And that's the power of this, is we use the head physio dashboard. And in this scenario, it's the IA Rebook Rate, which is, we want to get that to 90%. We know that there's key actions that need to happen in stage 1, stage 2, and stage 3. Okay, we look at that, and then we look at the patient value outcomes, and we can see where the problems are lying. So hopefully at this stage now, you can see the power of this. Your IA Rebook Rate is obviously your patients that have rebooked and turned up to the second session. Hopefully by now you understand that there's 3 key stages the patient needs to go through in order to achieve that. The patient needs to buy into the treatment plan, which again can be an issue with self-trust of the treatment plan not speaking the value outcome language, and it looks too hard because it's all about exercises. I don't have the self-trust to actually do this, that it's worth my time and my money. Or you can have trust of a therapist issue for a patient where the therapist can't make sense of the patient's symptoms, so their explanation of the problem solution and plan is poor, or it didn't happen at all, so that there was no treatment plan to buy into in the first place and it was vague. Okay, in that scenario then we have to give the therapist the skills and the knowledge to actually make sense of the patient's symptoms, which is where our hub and our clinical tools help therapists think and problem solve. Okay, and then the other objections, it's going to be time or money, which again, if we talk about patient value outcomes, then that's going to overcome those objections because they can see that they're the things that they're actually getting in return as opposed to a load of exercises. So they need to buy into the treatment plan, they need to feel a difference in the first session, and they need to feel the difference between session 1 and session 2, which is stage 3. Okay, so the key inputs will be different depending on stage 1, which again, you can have a clinical confidence issue, they need a clinical system to help them make sense of the symptoms, or they need a framework to confidently explain the problem, solution and plan for the patient. A stage 2 problem is the clinical reasoning of what I need to treat first, where my alignment of my treatment plan, it's misaligned with the patient value outcome. So I'm doing a hands-on technique, but I'm not aligning it to optimize for the outcome that the patient wants. And then stage 3 is the same, but with rehab. I'm not giving them the right rehab exercises that's going to maintain the progress or create opportunities where the patient can feel a difference and continue to feel the progress between session 1 and session 2. So they're the key things that need to happen. Okay. Again, identifying the gaps, the numbers aren't going to lie. Okay. So if you want some help with this, if you're a clinic owner and you want to install the head physio dashboards, patient value outcome culture, very, very easy to do. Okay, we've done all the heavy lifting for you. We have got every resource that you need to do this. We've got every cheat sheet in order to install this very, very quickly for you. We'll train your team if you want us to, okay, in terms of they'll have access to our therapist mentorship. They'll even have access to a resource of how to understand the head physio numbers so that they can be self-managing clinicians, self-managing therapists that can look at their numbers, look and easily identify which stage problem it is, and then what actions they need to actually start doing or stop doing. Okay, it's that simple. If you don't want business coaching, then that's the Go To Clinic Mastermind program. If you don't want the business coaching aspect of it and you just want us to train your clinicians for you, we have our Train My Clinician pathway also. Okay, so that's where we'll use your head physio numbers. If you don't know the head physio numbers, we've got cheat sheets for you to find them easily. Your admin can do that for you. We'll use those numbers to train your team and improve your clinicians, get up that clinical standard. Or if you're a therapist working in someone else's private practice and you were probably remind me of myself in my early days where you're just hungry for knowledge, you want to be the best clinician you can be, you're on that journey to clinical excellence, and you know that language of high performance is numbers, you want to improve your own numbers, then the Go To Therapist Mentorship is for you, and we will help you improve those numbers and build a clinical step-by-step system to give you the confidence to pass all through those 6 stages. Okay, so that's it for this week. In the next episode, I'm going to cover some of the other key metrics, but they're the key things we want to focus on really if we want to improve our patients' IA Rebook Rate. Okay, so I'll see you on the next episode and we'll go into some of the other metrics then. Thanks for tuning in to this week's show. I hope you enjoyed it. Now, if you'd like a free copy of my Head Physio Systems 6-step checklist that I use to personally audit my own therapists to make sure that they can keep patients progressing even when the pain is eased, so that we can ethically increase our patient numbers, our revenues and referrals, head over to www.thegotophysio.com/checklist and I'll get that sent straight over to you. That's it for this week. I'll see you in next week's show.